I'll be speaking about torsional C-chop. I am Dr. Gaurav Mishra from India. In this short video, I'll be showing you an interesting, quick yet safer chop technique, different from the traditional regular chop technique, stop and chop technique, which is practiced in our day-to-day life. I call this technique as torsional crater chop or C-chop. It has got its own advantage, which in my experience is easier and can be done routinely on a daily basis. In this video, I will show you my incision technique, which is a two-port incision, not a three-port incision. I make a regular capsular access of 5.5 to 6 millimeter. I do not do rotation of the nucleus, I just do my hydrodissection. Then I mark the central area with the Sinskey hook, which is approximately 2 to 3 millimeter. After marking the central nucleus, I use the torsional phaco just to make a crater according to my depth. It may be slightly smaller in soft cases and slightly bigger in harder cases. Then I use the phaco just to impinge the tip of the crater and break the nucleus into pieces. You can see my Sinskey hook is not going beyond the rexus margin, and all the fragments are coming to the nucleus tip without even moving my phaco handpiece. And you can see my IOP is 30 millimeters of mercury. So the advantage from the traditional stop and chop technique is that you are using a torsional technique rather than a longitudinal phaco, and it is difficult in small pupil and harder grades of cataract. It also pushes the nucleus, thereby putting stress on the zonules, and it is very close to the rexus margin. This may lead to PCR while doing the trenching and breaking the nucleus, or while cracking, and may also lead to zonular dehiscence because of the forces exerted. Since longitudinal ultrasound produces more heat energy, 64% more, than the torsional, there may be chances of wound burn. In small pupils with shallow AC, where it is difficult to put expanders and the working area is limited, with high chances of complications and more maneuverable processes, it becomes a cumbersome process. We do not get idea about the rexus margin, which may tear while doing the surgery. So this new technique involves making this rexus 5.5 millimeter, marking a center 2 to 3 millimeters with a Sinskey hook, not with the sharp hook, using the thickest part of the nucleus, which is the most difficult part to crack, and deepest part, just debulking the central part using just the torsional phaco and making the crater depth of adequate size to have an idea about the thickness of the nucleus without putting stress on the zonules. This technique can be applied to all types of cataract from grade 1 to grade 4 without going into the periphery and utilizing the central thickest part and the central deepest part of the nucleus. Once the crater is made in soft, a smaller one; in dense, a larger crater. After debulking with the torsional phaco, the longitudinal phaco comes into force and just impinges on the nucleus, and with the Sinskey hook just adjacent to the phaco tip. It breaks the nucleus without going into the periphery. The nucleus segments can easily be fed into the phaco tip without any difficulty with the help of the Sinskey hook. So in this, lesser vector forces are applied. This can be done in all types of cataracts. So here I'll be showcasing the different types of cataracts. First is the softer cataract, in which you can see that a crater has been made and you have enough space to do the things. without going into the periphery. Now the moderate type of cataract comes. It seems to be not very soft cataract, but it is a slightly harder cataract. The same principle is to be followed, but slightly increase the size of the central marking and then debulk. You are always away from the posterior capsule. Now comes the white cataract. It is definitely a very hard cataract, but yes, you can follow the same principles according to your suitability, size of the crater, and the depth of the crater. You have enough size to see where you have to impinge and break the nucleus. Even in small pupils, in this case, you can see the pupil is small, not dilating with the intracameral dilators. You have small space to work. You cannot use expanders because of the shallow AC. You have small area to work, but in this case also, you can successfully do this maneuver without any complications. What I have done in my last 1 to 1.5 years is that I have usually performed this technique in more than 1,000 cases with zero PCR and zero zonular dialysis. The cornea edema has gone down by 40%. The energy consumption has gone down by 20%. The duration has decreased and the average fluid consumption has also decreased. So the advantages of this C-CHOP is it is always away from the rexus. There is no need to go deep towards the PC. Uses less ultrasound power, less heat generation. There is less stress on the zonules, less working radius, and fluid usage is minimized. More convenient for small pupils, can be done in all types of cataracts, even pseudo exfoliation cases, and it has a lesser learning curve. So we can adapt from stop and chop technique to this technique for beginners and even for experienced surgeons. Thank you so much.